Mr. Holmes, you've been talking about some of the rural issues, and I appreciate that because my district is larger than the state of New Jersey, and you indicated that your territory that you cover is about the size of New Jersey, or a little bit less than that. And one of the things that I've that's been rattling around in my head is that the telemedicine issue that you touched on earlier is that we ought to be able to figure out a way to save money long term, maybe not initially, but long term, by using telemedicine, and not only save some money, but increase the effectiveness of the care in the rural areas, or at least make it more accessible. For example, I have a bill in that deals with making sure that folks, by telemedicine, talking to the appropriate neurologists, et cetera, can get a quicker response on getting the TPA in the case of a stroke, because obviously if you're in a rural area, sometimes you can't get to the hospital where the right doctor has to look at you currently to give that medication, but we could speed it up. You mentioned that you all are providing some services for mental health. I think that's extremely important, because if we can catch that, just like with the stroke, instead of having somebody in long-term care, which we've talked about and how expensive that is, TPA can stop a lot of that. Likewise with mental health, if we catch it early in a regular clinic, and what we found, we're doing that a little bit in my district now, what we found is that people are much more likely to go to the clinic, the community center, if they can just step into the other room and get the mental health, even if it's by telemedicine, because we don't have the ability to have population to have psychologists or psychiatrists in every one of those communities. But there's still a certain stigma. Maybe that's not the way it's supposed to be, but there is, particularly in rural areas, to getting mental health services. If they can just step into another room of the clinic, nobody knows whether they're getting their foot looked at for toe fungus or whether they're getting a mental health evaluation. So just some comments on that, and do you believe that there might actually be some savings there long-term, particularly in rural settings, because we prevent folks from having more serious maladies?
I believe there are opportunities for cost savings by integrating behavioral health into primary care along with medical services. We have a couple of rooms set up in some of our clinics that have the telemedicine capabilities, the hookups for behavioral health care. Those patients are scheduled routinely. There is no indication that it's a specialty behavioral health visit for that patient when they're in the waiting room. And some of the other things we do is that we do have some behavioral health specialists that come in from some of the local mental health agencies to our clinics, and they have office space and exam room space embedded right into our other space. So we try and care for the patients in the best way that we can within the local situation, within the local facilities. There still are reimbursement challenges with telemedicine. The originating facility is not usually a part of the reimbursement methodology, so you have to build the infrastructure without having payment for that infrastructure. You have to maintain it. You have to have enough bandwidth to have interactive television and those interactive conversations.
All right, let me springboard off of that. And I believe I've got my names right. Sometimes I get them wrong. But the Stark Act currently, if I understand correctly, prevents us from using some of our facilities in conjunction with a hospital that might be willing to pay for some of that infrastructure, because at one time they were worried about collusion and raising the bills. Today, I've got underserved areas. I could use some space in a nursing home, long-term care facility, and put in some telehealth stuff, even if it was in conjunction with the hospital. Because in all fairness, I've only got one hospital that's really in competition if you're talking about somebody having a heart attack, but my folks have to travel about 45 minutes to get there. So do you think we need to also look at maybe relaxing some of that, particularly when we can get into underserved areas?
Antitrust issues are certainly an issue for medical delivery, especially now when we're seeing the development of large systems of care, and yet we have small providers that are trying to deliver services in a cost-effective way. Small areas don't have the depth of resource to have competitive services. We have to find the best way to deliver that care to our populations, but we have to be, at this point, careful of antitrust issues, and it's always something that's in the back of our minds.
So what you're saying is we have to try to figure out the balance. We'd prefer to have competition, But where there is no competition, maybe we need to take a look at giving some flexibility on the antitrust issues to make sure that we're getting services there.
Yes, sir, I agree.
All right, I yield back, Mr. Chairman. Thank you.
Thank you. The gentleman's time has expired, and now recognize Mr. Lujan from New Mexico.
Thank you,
5
Mr.
minutes.
Thank you, Mr. Chairman.